We know the woman who got it in Hong Kong, the Canadian who got it from the doctor in Hong Kong that had it, she was in the hotel with the doctor. That's how she got it. They were on the same floor. She got on an airplane, flew to Canada, came home. Her family thought she had congestive heart failure because she was 80 and she was on a trip. And the doctor said, oh, she just has congestive heart failure. In Canada, socialized health care. They sent her home to die. She did that. She went home and died. Then her son got it, because he was taking care of her. He was nurturing her. He was in his 40s. He comes back to the hospital, and he gives it to everybody in the hospital. So, you know, it's amazing how these things happen. Outbreaks are going to occur simultaneously in the United States. We've seen that with this current round of H1N1. Everybody got it it started in Southern California and Texas, and then we've had a lot more, but it ended up like in Michigan in 5 seconds because people fly. It ended up in Chicago in 5 seconds because people fly. And we won't have vaccines, so you can't depend on a vaccine at all. It's not going to happen. People are not going to come to work. We're not going to have supplies. We have a just-in-time economy. You know about that in the OR, where we only have enough supplies for a few days. Well, what happens when the truck drivers can't bring those supplies to you? Transportation is interrupted. We aren't going to have supplies after 3 days. So how do you get prepared? You need to be aware, you need to get educated, you need to plan, and then you need to practice. So awareness starts at home. And I imagine most of us are not aware at home. There are individual checklists, which I'd be happy to come back and talk to you guys about. How do you get prepared at home? You can visit pandemicflu.gov. They have great checklists online. It's easy to get prepared at home, and you should get prepared at home. All of these different organizations should be helping us to prepare, but I suspect most of us don't have churches, most of us don't have schools that are helping us prepare. I think some of us, though, had kids that had to come home from school during the first outbreak, yeah, because the schools... We're very particular about our kids in America. If our kids get sick, we get angry at the government, so they close the schools down, but they didn't close the hospitals down or tell us to go on alert. So individual prevention, hand washing, bacterial soap, stay away 3 feet, sneeze into the crook of your arm. If you're sick, stay home. I don't know if that works for us, though. I know that I'm told I can't have a sick day, so I don't know about nursing, but we have to come to work. Public health preparedness. Always maintain good practices at home. Visit www.redcross.org and look up Pandemic Preparedness. Always keep a 90-day supply of food at home. Why? Because of what I told you earlier about that 3-day just-in-time economy. Safeway is going to be done with food in 1 day. So you have to have canned food and water available at home. At present, the best alternative is prevention. There's no vaccine. Social isolation will not work. We aren't going to have a vaccine before this fall. It's already July. We may get priority as healthcare providers, but UC has not made a statement about whether or not we're even going to get priority. And it's already July, so I doubt that they're going to. We have to cohort patients, so when patients come in, we need to keep them in an area. A few weeks ago, we had a patient come in. I don't know if Patty's here, but we had a patient come into the operating room that was being tested for H1N1. I said that we needed to protect everybody, including our nurses, because we were going to be intubating this patient, and I was given the hardest time you could possibly imagine. We did not have the proper equipment. It went clear up to Dr. Miller, and it went all the way up to the chief medical officer, and they just got mad. They didn't do anything. They got mad that I brought it up and that the nurses didn't want to go in the room with H1N1. Then they told me, oh, well, the patient was negative, and now we know the H1N1 test. You're shaking your head, so you know, right, Jeff? The H1N1 virus doesn't, if it's negative in our lab here, doesn't mean the patient doesn't have it. They have to send it to a state lab, and the state lab determines if the patient has it or not. So that's going to take another week, and while that whole week is going on, we're operating on the patients and getting infected. So we have to have available treatment. Antivirals may lessen the impact, but they don't work. There's only 2 approved FDA antiviruses, the antiviral drugs, Tamiflu and Relenza. Everybody goes, oh, I'll just rely on that. You can't, because you have to take it almost before you get symptoms. The very first day you get symptoms. So unless you have it in your pocket, and I don't think anybody here does. I tried to get some from my own doctor, and the pharmacies are not releasing it. I have a prescription, can't get it. The national stockpiles have goals to treat 80 million people. How many people live in the United States? It's not enough. So not even healthcare providers are going to get it. The vaccine is the best defense But we don't have a vaccine. So what good is that? We don't have a vaccine. The government isn't strong enough. The vaccine companies have too much political power. They don't want to keep making the vaccine. They don't make a profit on it. So that's the bottom line, is the profit. So what can we do in healthcare? We aren't going to be able to meet peak demands. We don't have surge capacity. What we have to do is protect ourselves, because we're going to see a huge number of patients coming in, and we can't protect ourselves right now. I'm going to skip this slide. So what do we have to do? We have to think about where we're going to divert patients. We have to think about diverting patients out of the OR. They don't need to come to the OR for elective procedures. They don't need to come to the OR unless we can protect ourselves. If we can't protect ourselves, we'll all be dead. Half of us will be dead in a very short period of time. So hospitals are going to become overwhelmed. Despite all this business about we have all these, scenarios where we practice, et cetera, et cetera. Has anybody ever gone to any of those scenarios where they practice for, do you ever see doctors there? Interesting, because they don't let the doctors out to go to the scenarios. Now, if you think that you can control the doctors, you got to let me know, because you got to teach me how to do it in the operating room, because the surgeons here are out of control. And I don't know, and the emergency medicine doctors are probably the same way. They all have a mind of their own. They don't think in teams here at all. So if that happens and 100 patients come into the emergency room, and then the anesthesiologists run down to intubate these patients and come right back upstairs to do operative procedures, who gets infected? We all do. So we don't have enough mechanical ventilators. We all operate here with one extra ventilator. That's it. We don't have a stockpile of ventilators. I know that for a fact. We also don't have portable ventilators. We don't have small ventilator packs like you saw on the floors in Katrina, in the airport, where people were put on ventilators while they were waiting to be transported. We don't have any of those. The hospital told me that they're going to rely on the stockpiles from the public health department, and the state of California has 5,000. That's it. It's not enough to ventilate even what's going to happen here in San Francisco. So staffing is going to remain the biggest challenge. Preparedness is the most important thing you can do right now. Be aware. So today I hope I've made you aware. Get educated. Understand that you're not going to be able to be protected by a vaccine or Tamiflu. Communicate with each other. And now what I'm going to show you is how you can prepare, okay? The N95, this only takes 3 minutes. Everybody knows what it looks like. Does anybody know why it's called an N95? Let's have open discussion. Anybody know? Yes? No? Just say no if you don't know. Anybody have a guess? Does anyone want to guess where that 95 comes from? Huh? No, not the year. Good guesses, though. That's good. You guys were looking at the strain stuff. 95, this is really bizarre, comes from 95% of the particles being presented to the mask are filtered. Only 95%. So that means 5% are not even filtered. So remember the sneeze? If someone sneezes around you, 5% of the particles get through the mask. So why do they have us wear it for TB? Well, they have us wear it for TB because, number one, it's affordable, it's easy to stock, and TB is not deadly. TB won't kill us. We have great drugs for TB. It's very rare to have a fulminant episode of TB. TB doesn't kill 30 million people in one pop. TB doesn't kill 1 billion people in the world in one pop. Influenza does. So if you're talking about kill rates of upward of 50%, do you want to have an N95 on? You make up your mind. You're intelligent. I don't. The other interesting thing about the N95 is it filters 0.3 micron particles or bigger. And everybody can read that one. No one has ever done a study in the history of making of this mask to show that it prevents viruses from getting through. Not one human being. Not a doctor, not a scientist, nobody. And they're telling us to wear it. I have to ask you to ask yourself why. I mean, I'm not a, what do they call those things that ran off the cliff into the water and killed themselves? A lemming. Maybe everybody else is, but I'm not. What you need is a powered air purifying respirator. It should be used for all intubations, all bronchoscopies. That's the current CDHS guideline. It's also now the current Institute of Medicine guideline. The CDC is hedging and going back and forth like this.